Good morning. We are Group 5 of BSN 1F and we will be discussing thoracic and lung, heart and neck vessel, breast and lymphatic assessment. Before we begin, let me first introduce to you the members of the group. We have myself, Laprel Angeline B. Gomez, Almira Ivy Guzon, Hans Vincent R. Itit, and Melcher A. Hammond. The first topic to be discussed is the thoracic and lung assessment. For the learning outcomes of this topic, we have firstly to define the following terms: pectus excavatum, pectus carinatum, pleural friction rub, wheeze sibilant, wheeze sonorous, crackles fine, orthopnea, crepitus, and crackles coarse. Secondly, to identify anatomical chest landmarks, structures of the anterior or posterior thoracic cage, structures of the anterior vertical lines, posterior vertical lines, and lateral vertical lines. Third, to compare the different breath sounds as to normal breath sounds and adventitious breath sounds. Fourth, to discuss the steps in assessing the thorax and lungs using the different techniques in physical assessment, the normal and abnormal findings in thoracic and lung assessment, sequence in palpating, percussing, and auscultating the posterior and anterior thorax, nursing responsibilities before, during, and after thoracic and lung assessment, different assessment findings for the following disorders: chronic bronchitis and pneumonia. Fifth, to compare the different percussion notes. Sixth, to differentiate the lobes of the lungs. Seventh, to locate the ribs and intercostal spaces. And lastly, to demonstrate beginning skills in assessing the anterior, posterior thorax and lungs.
For the first zero, we will be discussing the terms related to thorax and lungs.
Pectus excavatum. The growth abnormality of the cartilage that links the ribs to the wall breastbones causes pectus excavatum, which is a congenital chest wall malformation. When you do this, you'll notice that your sternum is depressed and your chest seems sunken or funnel-shaped. Pectus carinatum. It is a rare birth abnormality that causes a child's breastbone to protrude outward in an unnatural way. Sometimes the deformity isn't apparent until the adolescent growth surge has passed. Pleural friction rub. A scratchy breathing sound caused by inflammation of the tissues around your lungs is known as pleural friction rub. Usually the sound is creaky or grating. Wheeze, sibilant. When the airway becomes clogged and restricted, a higher pitched, harsh, continuous whistling sound is produced. When listening to an asthmatic sufferer, these are the common wheezes you'll hear. Wheeze sonorous. Wheezes with a snoring, gurgling, or comparable quality to a low-pitched groan that is more evident on exhalation are known as sonorous wheezes. Mucous fluids, lesions, or foreign things might clog the major airways, causing sonorous wheezes. Crackles, fine. Fine crackles are high-pitched, short, discontinuous popping lung noises. The sound of wood burning in a fireplace, hook and loop fasteners being pulled apart, or cellophane being crumpled is also comparable to fine crackles. Orthopnea. An orthopnea is a shortness of breath that occurs when a person is lying down, but it goes away when they stand up or sit up. Orthopnea is a common sign of heart failure or lung disease, but it can also be caused by a variety of other illnesses. Crepitus. When roughened articular or extra-articular surfaces rub together, it's called crepitus. Crackles, coarse. Like pouring water out of a container or peeling open Velcro, coarse crackles are lower pitch and moist sounding. Adult respiratory distress syndrome, early congestive heart failure, asthma, and pulmonary edema are all common causes of this sound in the lungs.
CLO number 2. Identify anatomical chest landmarks, structures of the anterior or posterior thoracic cage, structures of the anterior vertical lines, posterior vertical lines, and lateral vertical lines. Anatomical chest landmarks. The thoracic cavity is made up of 12 pairs of ribs that connect to the vertebral bodies of the spinal column and the posterior thorax. The first 7 pairs of ribs in the front thorax are connected to the sternum or breastbone via cartilage. The sternum is not attached to the lowest 5 ribs. Costal cartilage connects the 8th, 9th, and 10th ribs to one another. The 11th and 12th ribs, often known as floating ribs, are not linked to the sternum in any way and move up and down in the anterior chest to allow for full chest expansion. Structures of the anterior or posterior thoracic cage. Here on the left side is the anterior thoracic cage, and here on the right side is the posterior thoracic cage. Structures of the anterior vertical lines, posterior vertical lines, and lateral vertical lines. Anterior and lateral vertical lines. The midsternal line is a vertical line that runs down the middle of the sternum. The parasternal line is a vertical line running along the lateral edge of the sternum. The midclavicular line is a vertical line that is traced in the middle of the clavicle. The anterior axillary line is a vertical line along the anterior axillary fold. The mid-axillary line is a vertical line at the midpoint between the anterior and posterior axillary line. And last, the posterior axillary line runs along the post-axillary fold. Posterior vertical lines. The scapula line is in the inferior angle of the scapula. The spinous process is a bony projection of the posterior of each vertebra. The midspinal line is a perpendicular line down the middle of the vertebral column.
Compare the different breath sounds as to normal breath sounds and adventitious breath sounds. In normal breath sounds, they are classified as tracheal, bronchial, bronchiovesicular, and vesicular sounds. The impact of body structures on air passing through airways creates the pattern of normal breath sounds. In adventitious breath sounds, the term adventitious sounds refers to sounds that are heard in addition to the usual breath sounds. Crackles, rhonchi, and wheezes are some of the most common adventitious sounds you will encounter. The normal findings of breath sounds are loud-pitched bronchial breath sounds over the trachea, medium-pitched bronchovesicular sounds over the mainstream bronchi between the scapulae and below the clavicles, soft, breezy, low-pitched vesicular breath sounds over most of the peripheral lung fields. In adventitious breath sounds, crackles, small clicking, bubbling, or rattling sounds are in the lungs. Rhonchi are sounds that resemble snoring. Stridor, wheeze-like sound heard when a person breathes. And wheezing, high-pitched sounds produced by narrow airways.
Steps in assessing the thorax and lungs using the different techniques in physical assessment. Fremitus is a vibration transmitted through the body. In common medical usage, it usually refers to assessment of the lungs by either the vibration intensity felt on the chest wall and or heard by a stethoscope on the chest wall with certain spoken words. Tactile fremitus is known by many other names including pectoral fremitus, tactile vocal fremitus, or just vocal fremitus. Is a vibration felt on the patient's chest during low-frequency vocalization. In assessing the tactile fremitus, the following occurs. The patient is asked to repeat a phrase while the examiner feels for vibrations by placing a hand over the patient's chest or back. Phrases commonly used in English include boy oh boy and toy boat, as well as blue balloons and Scooby-Doo. 99 is classically included. However, this is a misinterpretation of the original German report, in which 99 was the low-frequency diphthong of choice. Vocal fremitus. The healthcare provider places the flat of their palms on the chest wall and then asking a patient to repeat a phrase containing low-frequency vowels such as blue balloons or toy for tots. An increase in tactile fremitus indicates denser or inflamed lung tissue, which can be caused by diseases such as pneumonia. A decrease suggests air or fluid in the pleural spaces of a decrease in lung tissue density, which can be caused by diseases such as chronic obstructive pulmonary disease or asthma. Crepitus in the lungs refers to the sound and sensation associated with subcutaneous emphysema, a condition in which air is trapped under the skin. It is characterized by palpable or audible popping, crackling, grating, or crunching sensation that can occur when air is pushed through the soft tissue in the chest. The diagnosis and treatment of crepitus is usually aimed at determining the underlying cause of subcutaneous emphysema. Healthcare providers may be able to diagnose subcutaneous emphysema and the cause through a physical examination. However, they may also need to perform more diagnostic tests, like a computed tomography or CT scan and a magnetic resonance imaging or MRI scan. The healthcare provider will palpate or apply pressure to the affected area, and a crackling sound can sometimes be heard or felt. Treatment usually involves correcting the underlying condition. Chest expansion must be assessed to determine the depth and quality of movement on each side of the chest. Both sides should be assessed for symmetry. Overall chest expansion. Take a tape and encircle the chest around the level of nipple. Take measurements at the end of deep inspiration and expiration. Normally, a 2 to 5 inches of chest expansion can be observed. Any lung or pleural disease can give rise to a decrease in overall chest expansion. It is typically low in patients with COPD. These patients have a very high FRC and have limited capability to expand the chest from this position. Symmetry of chest expansion. Have patients seated erect or stand with arms on the side. Stand behind patient. Grab the lower hemithorax on either side of axilla and gently bring your thumbs to the midline. Have patients slowly take a deep breath and expire. Watch the symmetry of movement of the hemithorax. Simultaneously feel the chest expansion. Place your hands over upper chest and apex and repeat the process. Next, Stand in front and lay your hands over both apices of the lung and anterior chest and assess chest expansion. Diaphragmatic excursion is the movement of the thoracic diaphragm during breathing. Normal diaphragmatic excursion should be 3 to 5 centimeters, but can be increased in well-conditioned persons to 7 to 8 centimeters. It is performed by asking the patient to exhale and hold it. The doctor then percusses down their back in the intercostal margins, starting below the scapula until sound changes from resonant to dull. That is where the provider marks the spot. Then the patient takes a deep breath in and holds it as the provider percusses down again, marking the spot where the sound changes from resonant to dull again. Then the provider will measure the distance between the two spots. Repeat on the other side. It is usually higher up on the right side. If it is less than 3 to 5 centimeters, the patient may have a pneumonia or a pneumothorax, in which a chest X-ray is diagnostic for either. The normal and abnormal findings in thoracic and lung assessment. Normal findings. The chest wall is symmetric without deformity and is atraumatic in appearance. No tenderness is appreciated upon palpation of the chest wall. The patient does not exhibit signs of respiratory distress. Lung sounds are clear in all lobes bilaterally without rales, rhonchi, or wheezes. Resonance is normal upon percussion on all lung fields. Abnormal findings. Respiratory distress, either mild, moderate, or severe. Decreased or absent breath sounds. Increased or decreased respiratory rate. Wheezing, rales, crackles, rhonchi or stridor. Retractions, accessory muscle use, or nasal flaring. Chest wall tenderness, chest wall bruising, rib tenderness, sternal tenderness. Crepitus, areas of increased and decreased tactile fremitus, depression or protrusion of the sternum. Sequence in palpating, percussing, and osculating the posterior and anterior thorax. Thorough evaluation of the thorax and lungs is an essential component of a complete physical examination. The traditional systematic approach involves inspection, followed by palpation, percussion, and then osculation of both the anterior, lateral, and posterior thorax. The experienced clinician may vary on order or use advanced techniques to further characterize abnormal findings. The posterior thorax is best examined with the patient sitting upright, arms folded across chest, and hands placed on opposite shoulders. This displaces the scapulae laterally and exposes more pulmonary parenchyma to the examiner's hands and ears. Patients unable to sit upright should be assisted to do so. Alternatively, the examination may be conducted while the patient is lying on his side. The anterior thorax may be examined while the patient is either upright or supine. Nursing responsibilities before, during, and after thoracic and lung assessment. Nursing responsibilities before the assessment. Read the client's history. Introduction to the patient. Informing the client of the process of the assessment and answering any concerns of the client. Nursing responsibilities during the assessment. Perform the examination. Apply the nursing process, namely, assessment, analysis or diagnosis, planning, implementation, and evaluation. Nursing responsibilities after the assessment. Gather and organize the data collected from the assessment. Different assessment findings for the following disorders. Chronic bronchitis. In physical examination, it shows cyanosis, wheezing, weight gain, diminished breath sounds, distant heart sounds. In test, arterial blood gases may show elevated carbon dioxide and decreased oxygen levels. In X-ray, it may show increased bronchovascular markings and cardiomegaly. Pneumonia. In inspection, it shows increased respiratory rate, increased pulse rate, guarding and lag on expansion on affected side. Children with pneumonia may have nasal flaring and or intercostal and sternal retractions. In palpation, it shows chest expansion decreased on involved side and tactile firmness is increased. In percussion, it shows dull over affected area. And in auscultation, it shows that breath sounds are louder than normal. Bronchophony, egophony, and whispered pectoriloquy is present. Crackles fine to medium.
Compare the different percussion notes. There are five common terms to describe percussion in the physical examination. We have the tympanatic, hyperresonant, dull, flat. For the pitch of the tympanatic notes, it's hollow, high. The intensity is loud, quality is drum-like sound, duration short. Findings for the tympanatic notes is an example location tympanic sound heard over the chest indicate excessive air in the chest, such as may occur with thorax. The hyperresonant sounds. Its speech is higher than resonance. Intensity is very loud. Quality is booming. Duration is longer than resonance. Hyperresonance indicates the presence of trapped air. So it is commonly heard over an emphysematic or asthmatic lung, occasionally over an thorax. The resonance sounds. Its speech is low. Intensity is moderate to loud. Quality is hollow. Duration is long. The findings of the resonant sound is a characteristic of normal lung show. Dull or thud-like sounds. Speech is medium. Intensity is medium. Quality is thud-like. Duration is medium. The findings and example location is over the liver and the kidney. Dullness can be percused over an lactic lung or a consolidated lung. Lastly, we have flat or extremely dull sounds. Its speech is high, intensity is soft, quality is extreme dullness, duration is short. Findings and example location is sternum. Flatness percussion over the lung fills indicate a massive pleural effusion.
For the sixth course learning outcome, we have the lobes of the lungs. The lung is divided into 5 lobes. Superior and inferior lobes exist in the left lung, while superior, middle, and inferior lobes exist in the right lung. The lobes are separated by fissures, which are thin tissue walls. For the right lung, to accommodate the diaphragm, which rises higher on the right side over the liver, the right lung is 5 centimeters shorter than the left lung. It is also 5 centimeters wider. The right lung's volume, overall capacity, and weight are all greater than the left lung's. There are three lobes in the right lung, namely the upper lobe, the middle lobe, and the lower lobe. The largest lobe of the right lung is the upper lobe. It stretches from the lung's apex to the horizontal and oblique fissures. It has three bronchopulmonary segments, namely the apical, anterior, and posterior segments. The smallest lobe of the right lung, lying between the horizontal and oblique fissures, is the middle lobe. It has bronchopulmonary portions on both the medial and lateral sides. The lower lobe of the right lung is the bottom lobe. It is located below the oblique fissure. It has bronchopulmonary segments on the medial, lateral, superior, anterior, and posterior sides. Now, for the left lung. The human left lung is smaller and thinner than the right lung, and the oblique fissure divides it into two lobes, one upper and one lower. Because of the area taken up by the heart in the left side of the chest cavity, the left lung only has two formal lobes. However, it does have a lingula, which is similar to a lobe. The lingula is a tiny tongue-like extension of the left lung, similar to the right lung's middle lobe. It has two bronchopulmonary segments, namely the superior and inferior segments. The cardiac notch, a concave impression sculpted to accommodate the shape of the heart, is a depression on the medial side of the left lung surface. Now, for the upper lobe of the left lung, the anterior and apical-posterior bronchopulmonary segments are found in the upper lobe of the left lung. It is on the other side of the oblique fissure. For the lower lobe, superior, anterior, posterior, medial, and lateral bronchopulmonary segments are found in the lower lobe of the left lung. For the seventh course learning outcome, we have the location of the ribs and intercostal spaces. The ribs partially enclose and protect the chest cavity, where many vital organs, including the heart and the lungs, are located. The rib cage is collectively made up of long, curved individual bones with joint connections to the spine vertebrae. At the chest, many rib bones connect to the sternum via costal cartilage, which are segments of hyaline cartilage that allow the rib cage to expand during respiration. Although fixed into place, these ribs do allow for some outward movement, and this helps stabilize the chest during inhalation and exhalation. The human rib cage is made up of 12 paired rib bones. Each are symmetrically paired on a right and left side. Of all 24 ribs, the first 7 pairs are often labeled as true ribs. These bones are connected to the costal cartilage, which the 5 other false sets are not. 3 of those connect to non-costal cartilage, and 2 are deemed to be floating, which means they only connect to the spine. The intercostal spaces, also known as interspaces, are the space between the ribs. There are 11 spaces on each side, and they are numbered according to the rib, which is the superior border of the space.
Demonstrate beginning skills in assessing the anterior, posterior, thorax, and lungs. These same steps are very popular today in assessment of all systems of the body. These steps are designed to take the nurse through the assessment in a logical and organized sequence. You first start with a very general inspection and history of the patient. Then your exam becomes more detailed as you begin to examine the interaction of all the body systems. So visual inspection is the first step of the examination. This is a very important part of the exam since many abnormalities can be detected by merely inspecting the thorax as the patient is breathing. Palpation is the first step of the assessment where we will touch the patient. Many breathing difficulties can be seen during this step. Some systemic problems can be detected during this part of the exam as well as just mechanical breathing problems. Percussing is usually helpful only in a limited capacity to the examiner. And auscultation is the process of listening to the breath sounds with the use of a stethoscope.
Moving on to the second topic of this report, we have breast and lymphatic assessment. For the learning outcomes of this topic, we have first to define the following terms: axillary lymph nodes, mammary gland, mastectomy, lactiferous duct, lactiferous sinus, tail of Spence, orthopnea, areola, nipple, Paget's disease, Peau d'Orange, mastitis, mammography, gynecomastia, and fibroadenoma. Second, to review the anatomy and physiology of the breast and lymphatic structures, anterior chest, breast quadrants, internal anatomic structures of the breast, and major axillary lymph nodes. Third, to enumerate the various methods and guidelines for palpating the breast. Fourth, to discuss the importance of breast examination. Fifth, to trace the normal changes in the breast during a woman's lifespan. Sixth, to briefly discuss the following: how to assess the breast and lymph nodes, the normal and abnormal findings in breast and lymphatic assessment, assessment findings of the following conditions: breast tumor, breast cancer, blocked lymphatic drainage, and nursing responsibilities before, during, and after breast and lymphatic assessment. And lastly, demonstrate beginning skills in assessing the breasts and lymph nodes.
Breast and lymphatic assessment. Axillary lymph nodes, also known commonly as axillary nodes, are a group of lymph nodes in the axilla and receive lymph from vessels that drain the arm, the wall of the thorax, the breast, and the upper walls of the abdomen. Mammary gland. The mammary gland is made up of connective tissue, fat, and tissue that contains the glands that can make milk, also called breast. Mastectomy. Mastectomy is a breast cancer surgery that removes the entire breast. A mastectomy might be done when a woman cannot be treated with breast-conserving surgery, which saves most of the breast. Lactiferous duct. The lactiferous duct are responsible for delivering the milk to the surface of the skin and out of the mother through tiny pores in the nipple. These ducts form a tree branch-like network that converges at the nipple. Lactiferous ducts are known by many names, including milk ducts, mammary ducts, and galactophores. Cooper's ligaments. Cooper's ligaments are bands of tough, fibrous, flexible connective tissue that shape and support your breasts. They're named after Astley Cooper, the British surgeon who described them in 1840. They're also known as the suspensory ligament of Cooper and the fibrocollagenous septa. These ligaments help to maintain the shape and structural integrity of your breast. The tail of Spence. The tail of Spence is an extension of the tissue of the breast that extends into the axilla. It is actually an extension of the upper lateral quadrant of the breast. It passes into the axilla through an opening in the deep fascia called foramen of Langer. Areola. The areola is a circular dark-colored area of skin surrounding the nipple. Areolae have glands called Montgomery's glands that secrete a lubricating oil. This oil protects the nipple and skin from chafing during breastfeeding. Nipple. The pigmented projection on the surface of the chest in the male and the breast in the female. In the mature female, ducts that conduct milk from the mammary glands to the surface of the breast exit through the nipple. The surrounding flat area of pigmentation is the areola. Paget's disease. So, This is a disease of bone that interferes with your body's normal recycling process, in which new bone tissue gradually replaces old bone tissue. Over time, bones can become fragile and misshapen. The pelvis, skull, spine, and legs are most commonly affected. Peau d'orange. So this is a French term meaning orange peel or orange skin. It is used to describe a symptom in which the skin becomes thick and pitted with a texture and appearance similar to that of orange peel. Mastitis. Mastitis is an inflammation of breast tissue that sometimes involves an infection. The inflammation results in breast pain, swelling, warmth, and redness. You might also have fevers and chill. Mammography. Mammography is a specialized medical imaging that uses a low-dose X-ray system to see inside the breasts. A mammography exam called a mammogram aids in the early detection and diagnosis of breast diseases in women. Gynecomastia is a condition of overdevelopment or enlargement of the breast tissue. In men or boys, the breast becomes larger. They may grow unevenly. Gynecomastia often happens when a preteen or teenage boy is going through the hormonal changes of puberty. Fibroadenoma. So fibroadenomas are common benign breast tumors made up of both glandular tissue and stromal tissue. Fibroadenomas are most common in women in their 20s and 30s, but they can be found in women of any age. They tend to shrink after a woman goes through menopause.
CLO number 2 reviewed the anatomy and physiology of the breast and lymphatic structures, anterior chest, breast quadrants, internal anatomic structures of the breast, and major axillary lymph nodes. The breast is located above the pectoralis major, serratus anterior, and rectus abdominis muscles. The anterior part of the chest contains a nipple, which is surrounded by the areola, a circular and hyperpigmented region of the breast. The breast is divided into 4 quadrants. The internal structure of the breast contains lobes, lobules, and bulbs that all connect through ducts, and ducts lead to the areola. Fat fills the lobules and ducts. There are no muscles in the breast. However, there are muscles under the breast to cover the ribs. The central axillary lymph nodes are located near the armpit's base in the adipose tissue.
Various methods and guidelines for palpating the breast. Before starting the palpation of the breast, it is important to ask the woman to indicate the exact location of any masses felt during self-examination. When palpating the breast, it is important to pay attention to the following features of any identified masses. Shape. The shape is the most common benign lesions like a cyst or a fibroadenoma have very regular borders, while cancerous nodules tend to almost always to be irregular in shape. Consistency. A mass that feels rock hard or otherwise very firm is probably malignant, while a rubbery or elastic consistency is a typical of a benign lesion. Relation to the skin. A lesion that is very fixed to the skin is usually malignant. Changes over time. Rapid changes of a lesion over weeks to months raise suspicions for cancer. Tenderness. Cancerous nodules tend to be a non-tender, while benign lesions are often particularly tender. A mass that changes in tenderness during the menstrual cycle is most likely begin. Patient positioning. In patient positioning, palpation of the breast starts with the patient sitting upright on the examination table. This position is exactly the same as the one used during inspection. Both hands lie relaxed on the patient's lap. Then ask the patient to lie supine on the examination table with both hands behind the head and repeat the palpation on both sides. This position allows the examiner to press any lesions against the chest wall, making it easier to detect abnormalities that may have gone unnoticed in the upright position. For the same reason, it also facilitates the exam of the nipple area for both nodules and discharges. The palpation technique. It is important to keep in mind the following points about the correct palpation technique. Palpation is best done by using the finger pads rather than the fingertips. One hand palpates the breast for any abnormalities while the other one sustains and stabilizes the breast. It is important to thoroughly and systematically palpate all the areas of the breast, including the tail of Spence in the upper outer quadrant. The most effective strategy when it comes to moving across the breast, based on the available evidence, is a lawnmower, where the hand moves up and down from one side to the other, describing vertical lines all across the breast. Remember to press the nipple against the chest wall to elicit any discharges if not spontaneously present. If the tenderness is present on one side, always start the exam on the non-tender side.
For the fourth course learning outcome, we have the importance of breast examination. A clinical breast examination is a procedure for identifying breast cancer and diagnosing and monitoring a variety of benign and malignant breast disorders that is carried out by a skilled physician. The following are the importance of breast examination. To understand how your breasts should look and feel, to identify signs of breast disease, and to initiate early treatment. In understanding how your breasts should look and feel, examination of the breast for unusual changes such as a lump near the armpit, increased thickness or fullness of your breasts, an inverted nipple, nipple discharge, pain and swelling, sores, or ridges can help in detecting breast or lymphatic issues early on by consulting with your doctor or seeking medical consultation about such changes. This can be done through regular breast self-examinations to become familiar with how your breasts normally look and feel. In identifying signs of breast disease, assessing breast and lymphatic health plays a vital role in early detection. With regular mammography and clinical breast exam, doctors may be able to detect breast disease or breast cancer, leading to early treatment. In initiating early treatment, detecting and diagnosing breast cancer at an early stage can improve long-term results. Such results include increased chances of survival, as an early stage typically requires less treatment. For the fifth course learning outcome, we have the normal changes in the breast during a woman's lifespan. A woman's breasts lose fat, tissue, and mammary glands as she gets older. Many of these changes are caused by the decrease in estrogen production that occurs with menopause. Presented is a table presenting the breast development stages that occur during a woman's lifespan. For the breast development stages, we have before birth, puberty, pregnancy and milk production, and menopause. For the before birth breast development stage, the breasts begin to form in an unborn infant inside the mother's womb. The mammary ridge, also known as the milk line, thickens in the chest area. The nipples and the beginnings of the milk duct system will have been established when the infant girl is born. For puberty, fat begins to accumulate in the connective tissue. The breasts enlarge as a result. The duct system begins to expand as well. Once ovulation and menstruation have commenced, the formation of secretory glands at the end of the milk ducts begins the maturation of the breasts. The following occurs to the breast during its development in puberty. During preteen stage, only the tip of the nipple is raised. The appearance of buds also happen. Breast and nipples are raised, and the areola grows larger. The presence of granular breast tissue also occur. The growth of breast occurs as well. The areola and nipple rise, followed by the formation of a second mound above the rest of the breast. Breasts have become rounded and only the nipple is raised in a mature adult breast. Many women also experience changes in breast texture during menstruation. For pregnancy and milk production, one of the first indicators of pregnancy is breast changes. The hormone progesterone is the cause of this. The dark regions of the skin around the nipples or the areolas also start to enlarge. The breasts rapidly increase as well. Nipple tingling or pain as well as soreness along the sides of the breast is experienced due to the expansion of the milk duct and the production of many additional lobules. The breasts are fully capable of producing milk by the 5th or 6th month of pregnancy. The areola also becomes larger and darker, and the blood vessels in the breast become more prominent. Lastly, for menopause, estrogen and progesterone levels start to fluctuate around this period. The connective tissue in the breasts becomes dry and loses its elasticity without estrogen. Breast tissue that has been prepared to produce milk shrinks and loses its form. This causes the saggy breasts that are common among women of this age.
For shallow number 6, we have breast and lymphatic assessment. For 6.1, how to assess the breast and lymph nodes. During inspection, the breasts are observed for asymmetric findings such as abnormalities in the shape of the breast, changes in skin color, skin dimpling or retraction, spontaneous nipple discharge. For palpation, the purpose of this exam is to thoroughly check the breast in order to palpate all of the tissue. The methods are discussed in the following sections. Allowing enough time for the exam improves its accuracy. This will depend on the size of your breast. The larger breast in particular will necessitate more time and attention. Lymph node examination. When a breast examination is conducted for suspicious of breast cancer, it is crucial to conclude the exam with a thorough inspection of the axillary lymph nodes to look for any metastatic lesion. 6.2. The normal and abnormal findings in breast and the lymphatic system. The normal findings: the nipple, breast tissue, and areas around the breast look normal and are normal in size and shape. A small area of firm tissue may be present in the lower curve of the breast below the nipple. Tenderness or lumpiness that occurs in both breasts. A clear or milky discharge such as the galactorrhea may be present with the nipple when squeezed. The abnormal findings: a firm lump or area of thickening may be present in one of your breasts. Changes in the color or feel of your breast or nipple may be present. A nipple may sink into the breast. A red or scaly rash or sore may be found on the nipple. A bloody or milky discharge such as galactorrhea may occur without stimulation. Spontaneous nipple discharge. Assessment findings of the following condition. For the breast cancer, it is conducted through ultrasound. For breast cancer, change in breast size or shape. Skin sampling. An example is thickening, swelling, or redness. Axillary lump. And nipple discharge, particularly the blood stain. For black lymphatic drainage, swelling in fingers, feeling stiff and sore when you wake up in the morning, cold hands and feet, chronic fatigue, depression, and bloating. The nursing responsibilities before, during, and after breast and lymphatic assessment. So, before, introduce yourself to the client and establish good communication with the client. Also, develop trust with the client and inform the client of the process of the assessment. Lastly, answer any questions for the client may have about the assessment. During, apply ethical evidence-based practice. Use critical thinking and problem-solving skills. Apply the following nursing practice, such as assessment, diagnosis, planning, implementation, and evaluation. And after, collect and properly organize all the data gathered from the assessment.
For the 7th course learning outcome, we have the beginning skills in assessing the breasts and lymph nodes. Practitioners use many techniques with success, and each examiner will likely develop his or her preferences. Regardless of which approach is utilized, it is important always to follow a consistent pattern to minimize the likelihood that anything is missed. These techniques include inspection, palpation, and documentation. For inspection, the breasts are first visually inspected with the patient in a seated position facing the examiner. The patient is instructed to place their hands on their hips as well as raise them above their head. This allows the examiner to assess the breasts in many positions and observe overall size, shape, symmetry, nipple size, texture, and color. Variations in any of these should be noted concerning previous exams, as well as in comparison to the contralateral breast. Areas of skin thickening, dimpling or fixation relative to the underlying breast tissue should also be noted on visual inspection. These can be exaggerated during movement as well as by asking the patient to flex the pectoral muscles with hands on the hips. For palpation, after completing the visual inspection, the patient should be instructed to lay supine. If a site-specific breast complaint is being evaluated, the examiner should begin his or her exam on the opposite or normal side. As one breast is examined, the other is covered for the patient's comfort. The patient should place the ipsilateral hand above and or behind their head to flatten the breast tissue as much as possible. The breast tissue itself is evaluated using a sequence of palpation that allows serial progression from superficial to deeper tissues. The overall consistency of the breast is documented, whether it be soft, firm, or nodular. Any masses or tender lesions are noted concerning their location in a conventional quadrant or clock face configuration. When documenting findings, characteristics of any abnormalities should be included, such as size, shape, texture, mobility, delimitation, tenderness, and approximate depth. Attention is then turned to the nipple areolar complex, where these tissues themselves are palpated for abnormalities. The examiner should assess for expressible nipple discharge by placing both hands on the breast on either side of the areola and gently but firmly pressing down into the breast tissue. Following a complete exam of the breast, the axilla and supraclavicular area should be palpated for lymphadenopathy. Lastly, for documentation, common terminology found in the documentation of a breast exam includes the following: symmetrical and asymmetrical, Shape, which may be described as ptotic, pendulous, any scars or deformities with descriptions. Texture, which may be described as soft, nodular, fibrocystic, dense, presence of inframammary ridge in large breasts. Masses, described as indicated above versus no masses evident. Nipple areolar complex, which may be described as pink, brown, inverted, discharge present or absent with description, presence of dry, scaly texture concerning for Paget's disease. And lastly, skin, which may be described as warm, dry, presence or absence of erythema, edema, putty orange appearance, open sores, and draining fluid collections. For the third and final topic, we have heart and neck vessel assessment. The learning outcomes for this topic include: first, to define the following terms: pulmonic, infarct, thrill, aortic, splitting, diaphragm, auscultation, bell, mitral, and systole. Second, to identify the anatomical position of the heart structures, valves or chambers, and major neck vessels. Third, to discuss the following: physiology of the heart, steps in assessing the heart and neck vessels, and auscultation of heart sounds, the normal and abnormal findings in heart and neck vessel assessment findings of the following conditions: mitral valve stenosis, chronic obstructive lung disease, and nursing responsibilities before, during, and after heart and neck vessel assessment. Fourth, to identify the anatomical sites of cardiac function. Fifth, to differentiate the cardiac sounds and murmurs. And sixth, to demonstrate beginning skills in assessing the heart and neck vessels.
Terms related to heart and neck vessel. Pulmonic. It means pulmonary or anything pertaining to or relating to the lungs. Infarct. Infarction is the death of tissue caused by a lack of blood supply, which is usually caused by a blood clot obstructing a blood vessel or a blood vessel channel narrowing. It's referred to as an infarct when the tissue is dead. Thrill. It is a pulsating vibration on the skin that is caused by an arteriovenous fistula or a loud heart murmur. Aortic. Anything relating or pertaining to the aorta, the main artery that carries blood from the heart and is responsible for the distribution of blood to all the parts of the body. Splitting. It's a result of an auscultation. This condition occurs when the aortic valve and the pulmonary valve are closed at the same time during inspiration. Diaphragm. The diaphragm, often called as the thoracic diaphragm, is a large muscle that separates the chest from the abdomen. Because of its alternating movement, this muscle aids in the inhalation and exhalation of air. Another possible meaning for diaphragm is one of the parts of a stethoscope wherein it is used to detect high-frequency sound. Auscultation. Using a stethoscope to listen to the sounds inside your body is known as auscultation in medical terms. There are no risk or negative effects to this simple test. Auscultation allows your doctor to get a good understanding of what's going on in your body. Auscultation and other related methods can be used to test your heart, lungs, and other abdominal organs. Bell. The bell is one of two heads on the stethoscope that can be used to receive sound. Mitral. Relating to or situated near the mitral valve of the heart. Systole. The blood is then pumped out of the heart and into the circulatory system's large blood arteries. As the heart contracts, the blood then travels to all the body's organs and tissues.
For shallow number 2, identify the anatomical position of the heart structures, valves, chambers and major neck vessels. The heart is located between your lungs in the middle of your chest, behind and slightly to the left of your breastbone, such as the sternum. The mitral valve and the tricuspid valve are located between the atria, upper heart chamber, and the ventricles, lower heart chamber. The aortic valve and the pulmonic valve are located between the ventricle and the major blood vessels leaving the heart. And also the heart has four chambers. The upper chamber are called the left and the right atria, and the lower chambers are called the left and the right ventricle. The carotid arteries are major blood vessels in the neck that supplies blood to the brain, neck, and face.
Heart and neck vessel assessment. Physiology of the heart. The heart itself is made up of four chambers, two atria, and two ventricles. The oxygenated blood returns to the right side of the heart via the venous circulation. It is pumped into the right ventricle and then to the lungs, where carbon dioxide is released and oxygen is absorbed. The oxygenated blood then travels back to the left side of the heart, into the left atria, then into the left ventricle, from where it is pumped into the aorta and arterial circulation. Steps in assessing the heart and neck vessels and auscultation of heart sounds. Heart sounds can be auscultated in the traditional five areas on the precordium, which is the anterior surface of the body overlying the heart and great vessels. Their traditional areas include the aortic area, the pulmonic area, Erb's point, the tricuspid area, and the mitral or apical area. The four valves areas do not reflect the anatomic location of the valves. Rather, they reflect the way in which heart sounds radiate to the chest wall. Sound always travel in the direction of blood flow. For example, sound that originate in the tricuspid valves are usually best heard along the left lower sternal border at the fourth or fifth intercostal space. So, traditional areas of auscultation. Firstly, in the aortic area, which is the second intercostal space at the right sternal border or the base of the heart. And then the pulmonic area, second or third intercostal space at the left sternal border, the base of the heart. Erb's point, third to fifth intercostal space at the left sternal border. Mitral, fifth intercostal space near the left mid-clavicular line, the apex of the heart, and then the tricuspid area, fourth or fifth intercostal space at the left lower sternal border. So alternative areas. In reality, the areas described above overlap extensively, and sounds produced by the valves can be heard all over the precordium. Therefore, it is important to listen to more than just 5 specific points on the precordium. Keep the fact of overlap in mind and use the names of the chambers instead of Erb's point, mitral, and tricuspid areas when auscultating over the precordium. Alternative versus the traditional areas of auscultation overlap and are not as discrete as the traditional areas. The alternative areas are the aortic area, pulmonic area, left atrial area, right atrial area, left ventricular area, and right ventricular area. Cover the entire precordium as you auscultate in all areas, and concentrate on systematically moving the stethoscope from left to right across the entire heart area from the base to the apex or from the apex to the base. The normal and abnormal findings in heart and neck vessel assessment. Observing the jugular venous pulse. So the normal findings with this is with the person sitting upright, the jugular venous pulse is generally not apparent. The vein is fully extended in this posture and pulsations may or may not be visible. The abnormal findings is that increased central venous pressure, which can be caused by right ventricular failure, pulmonary hypertension, pulmonary emboli, or cardiac tamponade, is indicated by fully distended jugular veins with the client's body elevated more than 45 degrees. In evaluating the jugular venous pulse, the normal findings is at 45 degrees or more, the jugular vein should not be distended, bulging, or projecting, and abnormal findings is Right-sided heart failure is indicated by distension, bulging, or protrusion at 45, 60, or 90 degrees. Keep track of whatever positions you notice distension in. Auscultation of the carotid arteries. The normal findings is there are no sound of blowing or swishing. Pulses are all the same strength, a 2 plus or normal with no difference in strength from beat to beat. And the abnormal findings is occlusive arterial disease is indicated by a bruit, which is a blowing or swishing sound created by turbulent blood flow through a constricted channel. A bruit may not be heard if the artery is more than 2/3 blocked. In palpating the carotid arteries, the normal findings is there are no thrills and the arteries are stretchy. And the abnormal findings are arteriosclerosis may be indicated by a loss of electricity. Thrills could be a sign of arterial constriction. In inspecting pulsations of the heart, the normal findings are the apical impulse can be evident or not. It would be in the mitral area if it was visible. During systole, the left ventricle moves outward, resulting in the apical impulse. Pulsation in the abnormal findings, pulsations which may also be called heaves or lifts other than the apical pulsation are considered abnormal and should be evaluated. A heave or lift may occur as the result of an enlarged ventricle from an overload of work. In palpating the apical pulse, the normal findings is the amplitude is often minimal, similar to a soft tap. The apical impulse may not be palpable in obese individuals or those with large breasts. In palpating for abnormal pulsations, normal findings are there are no pulsations or vibrations felt at the apex, left sternal border, or base. And the abnormal findings are a grade 4 or higher murmur is generally accompanied by a thrill or pulse. In auscultation of heart rate and rhythm, the normal findings are pulse is in 60 to 100 beats per minute with a regular rhythm. Resting pulse rate varies by age, gender, and ethnical racial factors. And the abnormal findings are cardiac output may be reduced as a result of bradycardia or tachycardia. Clients with abnormal beats should be referred for additional assessment. These erratic patterns could put the client at risk for low cardiac output, heart failure, or emboli. And auscultation for a pulse rate deficit if abnormal rhythm is detected. So in normal findings is radial and apical pulse rate should be identical, and pulse deficit may be an indicator of atrial fibrillation, arterial flutter, premature ventricular contractions, and varying degrees of heart block are abnormal findings. In assessment and finding of the following conditions: mitral valve stenosis. Patients with mitral valve stenosis may experience symptoms such as shortness of breath, fatigue, swollen ankles and feet, heart palpitations, fainting or dizziness, coughing up blood, chest pains. And mitral valve stenosis may be detected through the following signs: heart murmur, fluid buildup in the lungs, and irregular heart rhythm. In chronic obstructive lung disease, clues to diagnosis to chronic obstructive lung disease is shortness of breath, coughing, exposure to airborne irritants, childhood respiratory illnesses, and family history of respiratory disease. And in nursing responsibilities before, during, and after neck vessel assessment. So in before, begin with a focused interview exploring past medical and family history, medications, cardiac risk factors, and reported symptoms. And during, make sure the necessary equipment are prepared. And then conduct a physical examination which involves the interpretation of vital signs, inspection, palpation, and auscultation of heart sounds as you evaluate for sufficient perfusion and cardiac output. Assess the level of consciousness. The patient should be alert and cooperative. And conduct an inspection of the skin color to assess perfusion, jugular vein distension, precordium for abnormalities and extremities in the upper and lower. And lastly, in the after, summarize the data gathered, validation of data by the nurse, and then discuss and share findings with the patients.
CLO number 4. Identify the anatomical sites of cardiac function. The heart contains parts such as valves, walls, chambers, and blood vessels. The heart's valves consist of tricuspid valve, mitral valve, aortic valve, and pulmonary valve. The heart's walls consist of endocardium, myocardium, and epicardium. The chambers of the heart are the right atrium, left atrium, right ventricle, and left ventricle. The blood vessels in the heart are the arteries, veins, and capillaries. This is how the heart pumps out blood.
For the fifth course learning outcome, we have cardiac sounds and murmurs. Heart sounds are produced by valve closure. The opening of valves is silent. Normal heart sounds characterized as lub-dub or S1 and S2, and occasionally extra heart sounds and murmurs can be auscultated with a stethoscope over the precordium. First up, for normal heart sounds, we have S1. This is the first heart sound, which is the result of closure of the atrioventricular valves, the mitral and tricuspid valves. S1 correlates with the beginning of systole. S1, also referred to as the lub portion of lub-dub, is usually heard as one sound, but may be heard as two sounds. If heard as two sounds, the first component represents mitral valve closure, or M1, and the second component represents tricuspid closure, or T1. Variations of the S1 sound include accentuated S1, diminished S1, split S1, and varying S1. For accentuated S1, this sound is louder than S2. It occurs when the mitral valve is wide open and closes quickly. Examples for accentuated S1 include hyperkinetic states and mitral stenosis. For diminished S1, sometimes the S1 sound is softer than the S2 sound. It occurs when the mitral valve is not fully open at the time of ventricular contraction and valve closing. Examples for diminished S1 include delayed conduction from the atria to the ventricles, mitral insufficiency, and delayed or diminished ventricular contraction. For split S1, it occurs as a split sound. This also occurs when the left and right ventricles contract at different times, which is called asynchronous ventricular contraction. Examples for split S1 include bundle branch block and ventricular entropy. Lastly, for varying S1, it occurs when the mitral valve is in different positions when contraction occurs. Examples for varying S1 include rhythms and atrial fibrillation. For S2 of the normal heart sounds, this is the second heart sound which results from closure of the semilunar valves, the aortic and pulmonic valves, and correlates with the beginning of diastole. S2, also known as the dub in lub-dub, is usually heard as one sound, but may be heard as two sounds. If S2 is heard as two sounds, the first component represents aortic valve closure, or A2, and the second component represents pulmonic valve closure, or P2. S2 is heard best at the base of the heart. Variations of S2 include accentuated S2, diminished S2, normal or physiologic split S2, wide split S2, fixed split S2, and reverse split S2. For accentuated S2, it is louder than S1. This occurs in conditions in which the aortic or pulmonic valve has a higher closing pressure. Examples include increased pressure in the aorta and increased pressure in the pulmonary vasculature, as well as the calcification of the semilunar valve. For diminished S2, S2 is softer than S1. This occurs in conditions in which the aortic or pulmonic valves have decreased mobility. Examples include decreased systemic blood pressure and aortic or pulmonic stenosis. For normal or physiologic split S2, it can be heard over the second or third left intercostal space. It is usually heard best during inspiration and disappears during expiration. Over the aortic area and apex, the pulmonic component of S2 is usually too faint to be heard, and S2 is a single sound resulting from aortic valve closure. For wide split S2, this is an increase in the usual splitting that persists throughout entire respiratory cycle and widens on expiration. It occurs when there is delayed electrical activation of the right ventricle. Examples include right bundle branch block. For fixed split S2, this is a wide splitting that does not vary with respiration. It occurs when there is delayed closure of one of the valves. An example of this is atrial septal defect and right ventricular failure. Lastly, reverse split S2 appears on expiration and disappears on inspiration. It occurs when closure of the aortic valve is abnormally delayed, causing A2 to follow P2 in expiration. Normal inspiratory delay of P2 makes the split disappear during inspiration. An example of reverse split S2 is left bundle branch block. For extra heart sounds, S3 and S4 are referred to as diastolic filling sounds or extra heart sounds, which result from ventricular vibration secondary to rapid ventricular filling. For the first extra heart sound, we have S3. If present, S3 can be heard early in diastole after S2. S3 is often termed as ventricular gallop. For S4, S4 results from ventricular vibration, but contrary to S3, the vibration is secondary to ventricular resistance or non-compliance during atrial contraction. If present, S4 can be heard late in diastole just before S1. S4 is also called the atrial gallop. Moving on to murmurs. Normally, blood passes through the heart silently. However, there are some conditions that might cause turbulent blood flow, and a swooshing or blowing sound can be auscultated over the precordium. Murmurs may be systolic, diastolic, or continuous. Conditions that contribute to turbulent blood flow include increased blood velocity, structural valve defects, valve malfunction, and abnormal chamber openings, in which an example of this includes septal defect. For the first type of murmur, we have systolic murmur. Systolic murmurs may be graded based on their intensity. Grade 1 murmur, which is barely audible. Grade 2, which is faint but easily audible. Grade 3, loud murmur without a palpable thrill. Grade 4, loud murmur with a palpable thrill. Grade 5, very loud murmur heard with stethoscope lightly on the chest. And lastly, Grade 6, which is a very loud murmur that can be heard without a stethoscope. For the classification of systolic murmurs, we have systolic ejection murmurs, or SEM, hollow systolic murmurs, and decrescendo systolic murmur. For systolic ejection murmurs, these murmurs result from turbulent blood flow due to obstruction, either actual or relative, across the semilunar valves, outflow tracts, or arteries. The murmur is heard shortly after S1. The intensity of the murmur increases as more blood flows across an obstruction and then decreases. Causes of SEM include innocent murmurs, stenotic lesions, and relative pulmonary stenosis. For hollow systolic murmurs, these murmurs start at the beginning of S1 and continue to S2. Examples include ventricular septal defect, mitral and tricuspid valve regurgitation. Lastly, for decrescendo systolic murmur, this murmur is a subtype of hollow systolic murmur that may be heard in patients with small ventricular septal defects. Meanwhile, for diastolic murmurs, these are murmurs which are usually abnormal and may be early, mid, or late diastolic. The first diastolic murmur is the early diastolic murmur. These are murmurs that immediately follow S2. Examples include aortic and pulmonary regurgitation. For the second type of diastolic murmur, we have mid-diastolic murmurs, also called rumble. These murmurs are caused by increased flow or relative stenosis through the mitral or the tricuspid valves. For the third diastolic murmur, we have late diastolic murmurs. These murmurs are due to pathological narrowing of the atrioventricular valves. Examples include rheumatic mitral stenosis. For the last type of murmur, we have the continuous murmur. These are murmurs which are heard during both systole and diastole. They occur when there is a constant shunt between a high and low pressure blood vessel. Examples of continuous murmurs include patent ductus arteriosus and systemic arteriovenous fistulas.
CLO number 6. Demonstrate beginning skills in assessing the heart and neck vessels. The assessment of the heart and neck vessels is an important part of a complete cardiovascular examination. This examination is important as it can help in identifying any signs of heart disease and initiate early referral and treatment. Neck vessels. First is preparation. It is important to explain to the client the process of the examination and describe each step, as well as answering any questions the client may have in order to ease their anxiety. Second is inspection. Observations made in the neck region is the assessment of the jugular venous pulse. From the jugular veins, you can estimate central venous pressure and estimate the heart's efficiency as a pump. And third is auscultation and palpation. Patients with high risk atherosclerosis are identified using auscultation. Carotid examination is neither sensitive nor specific in most situations, but in the right clinical setting, it can provide valuable information that leads to particular diagnosis and treatments. Heart. First is inspection. This is the first step in heart assessment. In this step, pulsations on anterior chest over the heart is inspected. Second is palpation. This is the second step in the assessment of the heart. The apical pulse is palpated in the mitral area. Abnormal pulsations in this step are also palpated. and third, auscultation. In the step, the heart rate and rhythm of the apical pulse are auscultated. It is important to know beforehand resting heart rates, which varies by age, gender, and cultural factors.
This ends our report for thoracic and lung, heart and neck vessel, breast and lymphatic assessment. Thank you.